It gives me great pleasure to introduce our new president, Barry Helfmann. I was thinking about how to introduce him, and I will tell you his professional credentials, but I wanted to tell you, when I thought about it, I realized I could not remember a year when Barry wasn't serving in some function in AGPA. You have really served this organization. He has been chair of the certification board, chair of the affiliate society assembly, co-chair of our annual meeting when it was called that before it became AGPA Connect, secretary, president-elect, and now president. When he's not working for AGPA, he is managing partner of Short Hills Associates in Clinical Psychology, a group practice. He is formerly director of professional affairs of the New Jersey Psychological Association, adjunct assistant professor of psychiatry at UMDDNJ, and consultant to private practices. He has been awarded Psychologist of the Year and Lifetime Achievement Award from the New Jersey Psychological Association. He is past president of the New Jersey Psychological Association and the New Jersey Group Psychotherapy Society. He teaches and writes about professional practice and healthcare trends. The title of his talk this morning, his presidential plenary, is Why AGPA? Let's welcome our new president.
Thank you, Eleanor. I've said a couple times this week that Eleanor has been a terrific president and is a very tough act to follow. Before I give you what I want to say, I just want to acknowledge a few people. My lovely wife, Dr. Susan Marks, sits here. Without her, I wouldn't be here. She's really allowed me to take many of the positions I've had. She keeps the home fires organized, believe me, and without her, it wouldn't be possible. Our oldest daughter, Leanne, is here from Pennsylvania. She does not like the limelight, so I'm only going to say we're very proud of her. Our other daughter is currently a second-year law student in Boston, and I think today she's representing domestic abuse victims in court. We thought that was more important. And my two closest friends are here. Both of them, I'm thrilled they came. Mitchell and Susan Jacobson. Mitchell and I go back to the 7th grade. We were classified in the same cycle, shall I say. That could be a paper in and of itself. We travel very well with them. They're always cold, we're always hot, but it works. And next to them are our other very dear friends, Dr. Alan and Sue Lubin. Alan just retired as a pediatrician last year. Both Mitch and Alan are my go-to guys, and they're my tennis buddies. Now, their games have deteriorated over the years, but we're such good friends, I still play with them. Although one of us is always on the injured reserve list, and now is no exception. Okay, so, good morning, everyone. It's an honor to stand with you here, to look across so many faces, each representing someone whose career is helping others, helping them deeply in some of the most important ways. It's because of this depth, because of this importance, that AGPA even exists, to support our work, to promote it, to make us more effective. Today, I'd like to talk to you about that in more detail. I'd like to share with you my vision of why AGPA is so important, what it can do for us, and why it's so important that we give back as well. And so, that is what we're going to cover here, why we connect with AGPA. I'd like to open with a personal story, one that started when I was just 10 years old. And it took me 3+ decades to solve its meaning. My father once had a St. Crucifix medallion given to him by the Mother Superior of a Catholic orphanage in New Jersey. The medallion read, "O Lord, thy sea is so great and thy boat is so small. He kept it next to the compass of a rather small boat he owned along with the bank. He told me the boat was 26 feet, but when I looked at the registry, it was actually 24, but you know, who's going to fight for 2 feet? In the 1950s, there was no GPS, and he didn't have the new Loran navigation, probably still just being used by the military at that time. He had a compass, a chart with markings that showed red and green buoys. The fact that I stand here today is a testament to somebody up there looking out for me. There were so many times we'd be out in the ocean, miles from land, in this 24-foot boat, and I was sure England was our next stop. This Mother Superior wanted to make sure my dad came back, and she knew he shouldn't quit his day job as a navigator. But why would it matter to her? We weren't Catholic, but he was sure connected to this orphanage of over 200 boys ranging from newborns to 18-year-olds. Here's why it mattered. He was a dentist with an office in a blue-collar, working-class Irish Catholic town. These boys in the orphanage had no real ongoing medical or dental care, so he built a dental office himself and donated everything necessary to provide an ongoing weekly care. Every Wednesday morning, his day off, there he was for 25-plus years. Why did he do this? Many times when I was off from school, I'd go with him. No matter how many times I asked him why, I never got a straight answer. This was especially perplexing to me because, as truth be told, it was not in his nature to be altruistic like this. The fact that he missed all of my tennis matches in high school, where we were undefeated and #1 in the state for 3 years, and some considered me a bit of a minor star, made me jealous of how many of these boys adored him and vice versa. He was a rock star there. I asked my mom why he did this, and believe me, she was clueless. I even got my courage up and asked the Mother Superior during one of her many lectures to me about doing better in school. I stepped foot on this orphanage and it was like radar. There she was. She said, "It's God's will. He sent us an angel." It wasn't for another 30-plus years that I finally got it. I was a participant in an institute special group, and maybe you can guess what that group was. It was a group on narcissism. The group ended up being all about fathers, and it hit me. He felt like an orphan himself, and it was in the act of emotionally connecting with the orphanage that he felt whole and connected. And isn't this part of our story here? 30 years I had this question about my own father, and through my AGPA experience, I found resolution. This is a kind of work, and as you know, so much more that AGPA promotes. Just as I discovered my father's motivation, as clinicians, we try to help our patients understand their motivations and why they make certain choices. These include those that are adaptive and maladaptive. We even try to understand our own motivations and reactions to our patients, especially as the dynamics of groups emerge. And through this, we encourage acceptance of one's choices, healing, new directions, new actions, and new experiences in life. It's transformative work and very real in terms of the benefits to our patients, to ourselves, and to society as a whole. But today I want to really explore this because it's why AGPA is so important for us to be part of, to benefit from, and to support. So let's begin with the first area of AGPA's importance, and that's to society as a whole, namely to its importance in our healthcare system. If you Google the acronym AGPA, you'll generally find our group dominating the first page of search results. But if you Google healthcare in the U.S., primary care in the U.S., psychotherapy in the U.S., you're not going to find us listed. Why? I would argue it's because the world doesn't yet really fully understand the importance of our work. We do so much and cost so little in the grand scheme that the world of healthcare should be taking a much more serious look at us. And that's what AGPA will continue to push for, advocacy. But to make my point, let's look at some of the facts around this. We'll start with the healthcare landscape in general, where there really are two dirty little secrets that need to be brought to light, although many of you may know these already. The first is that healthcare in the United States is top flight. We're actually mediocre compared with the rest of the industrialized world. At best, we rank somewhere in the middle. Is it that bad? Last I looked, we were 13th. In fact, we are incredibly wasteful, with so many overpriced, duplicative, and even unnecessary services in the same geographic area. PBS NewsHour once pointed out, and I quote, "The U.S. system is known for over-testing and over-treating everything from CAT scans and MRIs, knee replacements, and coronary bypasses." As we all know, these are very expensive procedures. Some of the tests alone cost more than it would be to see a patient in group therapy for over a year. We do more than twice the average number of MRIs and CAT scans as compared with any other industrialized country. Of course, some of this is related to the need for tort reform and a cover-your-ass mentality. We also have the highest obesity rate in the industrialized world, and it continues to grow, especially in children. Given the connection of obesity to heart disease, stroke, high blood pressure, diabetes, gout, some cancers, osteoarthritis, and so on. You can imagine the impact of obesity alone on our healthcare costs. And those of us here today surely know the results that group work could have, helping people address overeating and other eating disorders, as well as their comorbid consequences. Now, this isn't to say that the United States is altogether failing in healthcare. We lead the world in medical research and cancer treatments, but we are spending more than twice the average of other developed countries while generally getting worse results, and this needs to be addressed. Now, the second dirty little secret about our healthcare system is that managed care has been an abject failure, and in the next 5 minutes I'm going to prove it. In 1993, our nation spent nearly 14% of its gross domestic products on healthcare. Used to be called gross national product, for those of you who remember economics. That's basically 14% of everything, goods and services produced in the United States for any particular year. That was up from 13% the previous year, which is more than we had spent the previous year since. In other words, costs were soaring. At that time, there was nearly $1 trillion spending on health care. Siri tells me that's 12 zeros. So beyond my math skills. So managed care, which is another name for the insurance industry, said they would reduce this 14% figure. And how would they do that? They'd get the fat out of the system. By managing the system, care would improve and costs would go down. And by the way, their game plan was simple. It was to restrict access and lower the fees paid to providers. So how have they done in this 25 years? Okay. Well, our percentage of GDP, which was 14%, has now climbed to almost 18%. And we're now spending not $1 trillion, but $3 trillion a year on health. That's twice the percentage of GDP that other developed nations spend, while again results have fallen short. So in my opinion, it's a hard sell to suggest managed care has worked. To me, it looks like it's been nothing more than cost shifting and tighter rationing. In fact, by now, most managed care companies acknowledge that case management does not work, and they have eliminated it for routine outpatient care. From what I can see, the one area that did improve was in certain public sector plans, such as Medicaid, where they were able to produce providers previously, due to very low reimbursement rates and administrative hurdles, many therapists stayed out of the system. Obamacare, or the Affordable Care Act, used that model in the expansion of Medicaid. Of course, we don't want to celebrate the crisis our country is facing, but we should celebrate that members of AGPA actually hold some of the solutions, and that AGPA is working to make this known when we remember that over 60% of visits to primary care physicians are at least partially, if not fully, for mental health reasons, and that over 2/3 of psychotropic medications are being prescribed by PCPs and not psychiatrists, nurse practitioners, and in a few states, psychologists. So we can see a world of opportunity opening up before us, opportunity for our success as practitioners and for better patient results. For instance, while 60% of PCP visits are mental health related, partially at least, the total cost of mental health services is somewhere between 4.5% and 5% of the total healthcare dollar. Outpatient care is probably 1.2%. This number includes psychiatric inpatients and substance use disorders, inpatient as well as outpatient treatment. And we all know group treatment is often the main treatment modality in both of these settings. So relatively speaking, we're seeing a small investment in perhaps the primary problem. We're seeing tremendous demand for work that comes at a greater overall value to the system. And when you look at the unintended economic consequences of not providing necessary therapy, our value is more obvious still. In short, the need is great, and the system ought to understand this and increase the use of our services. Let me give you a small case study example. In 2007, when I was working as the Director of Professional Affairs 1 day a week at the State Psychological Association, I was tasked with conducting an unofficial audit of the New Jersey State Health Benefits Plan for mental health. Interestingly, the official state audit was done for medical. They had an outside firm. They did a 130-page audit every year, and they had one sentence: mental health is not included. So this plan covered almost 900,000 lives, which is roughly 8% of the state's population. Neither the insurer nor the state agency could tell us the cost of providing the mental health program. They finally estimated 4.5%, which was about $40 to $50 million. Remember, this includes all inpatient care. If you do the math, it's $50 a person allocated for mental health treatment. Now, I didn't do this study myself. It was way beyond my pay grade. We hired a psychotherapy economist. His name was James Rich from the Midwest, whose background, by the way, was in being sober and in social studies. He was a social studies teacher. But he was well known, and he came into New Jersey and really took this apart. We were unable to obtain from them any data as to the medical cost offset savings, the number of primary care visits that were totally mental health issues, or the increased costs due to unintended substance abuse, disability claims, absenteeism, unsuccessful suicide attempts, and other comorbid medical conditions. So Mr. Rich did something very creative. He went to the national data and he applied it to New Jersey and ran an algorithm. By using national data, we estimated the dollar cost in New Jersey of unsuccessful suicide attempts alone in any given year, $80 million. That's just the economics. Has nothing to do with the human suffering. This was twice the cost of the entire mental health care program. So here it is, the bottom line. We made a series of recommendations, one which was, how about doing a real audit and finding out what you're spending, and stopping case management, which doesn't work. If they stop case management alone and encourage early intervention with primary care, integrative care, we estimated that the entire program, the 40 to 50 million, would be covered. In fact, that's not true. The actual number was 150 million. But I was afraid to include that in the report, concerned that I'd be called out for fake news before that ever was such a thing. But those were the facts before me. Again, this speaks to the solution we can offer to an overburdened healthcare system and how the solution for them means increased opportunities for each of us, improved healthcare for people as well. Everybody wins. And I think we can all agree that right now, a win in healthcare isn't just a good idea, it's probably essential to our future economic health. And a big win here might indeed be possible, especially if we get involved. Why? Because we have an elephant in this room that no one really wants to talk about. And who better to start such a difficult conversation than those sitting right here? First, let's face it, The current system that combines private and public insurance coverage, it's hard to imagine the system getting better. Having to answer to shareholders, private insurers have to focus on profits, period. The major carriers earn 12% net per year. That's net. And the not-for-profit companies like Horizons put away in the bank 6% net. Many of us as investors would be very happy with those numbers. At the same time, their real loss ratio numbers are closer to 50%, not the 80+% required by most state laws. Just so you know, loss ratio is very simply the amount of the premium dollar that goes into direct care. Mr. Rich did actually an official audit in the state of Vermont on their state health plan and came up with a figure of 50%. The carrier, by the way, was Magellan. In contrast, Medicare spends 92% minimum of each premium dollar in direct care, some years 95%. So on the one hand, this shows us that the government provider puts more towards our health than private companies. But on the other hand, here's where the elephant comes into being that no one wants to talk about. Medicare spends a disproportionate amount of its resources on end-of-life care. 1% of the United States population accounts for 30% of the nation's health care expenditures. Medicare spends 30% of its entire budget on beneficiaries during the last year of life. Because it's not driven by profits and will put more of the premium dollar into the nation's health system, I believe we need and will end up with a single-payer system. But the elephant that needs to be acknowledged and addressed, if we can do so, we will have the resources to cover our entire population's requirements. But end-of-life expenses are a highly emotional, moral, family, political, and societal challenge. Does increasing life by a few months, often a few poor quality months, justify the huge expense? Well, who better than group therapists to help initiate and lead such taboo conversations? Can you imagine us going into independent living facilities and setting up groups and having this conversation? I sure can. So I ask why we connect with AGPA, why we're part of this group, why we support it, and how it supports us. And the first answer has to do with its impact on society as a whole, specifically on our nation's healthcare system. We're at a breaking point in healthcare. We need to lower costs and improve results. My case examples show that by making more use and better use of mental health providers, we can actually lower costs in the system. I believe we can lead the charge on end-of-life issues. And there's more. What about the opportunity to bring group approaches to the office of PCPs? We can help with matters like medication compliance. We can offer theme-centered approaches. We can address the interrelationships between comorbid illness and psychological factors. In short, it seems like very small thinking if we try to fix our healthcare system by simply arguing about where the money should come from, when in fact there are ways to reduce costs and improve results. As AGPA members, we should and can play a role in these solutions. But to achieve this, evidence-based data has to become part of our therapeutic arsenal. We have to stop being afraid to demonstrate our effectiveness. Psychotherapy in general and group therapy in particular makes a tremendous difference in people's lives. Becoming comfortable with the user-friendly measures only furthers our cause and promotes group to its rightful place in healthcare. We don't have to prove that what we do works. We know it. We just have to demonstrate it. I think we can and will achieve this, and I believe AGPA will help this to come about. As it does so, AGPA will inevitably help each of us professionally. And this is our second reason for connecting with the group, supporting the organization and supporting one another. If AGPA can effectively communicate what we offer, we can drive the healthcare system to action, then demand will be there for more mental health therapy, including group therapy. Demand will ask for more therapists to be available, and it will certainly ask for experienced therapists who are CGPs to take leading roles. So for those looking to grow their business and perhaps give back more to society, this will be an opportunity. But AGPA provides more than just promotion of our services, more than just this future opportunity. What do we see here today? How do we benefit now? What about the emotional experiential learning, world-class training, opportunities for continuing education, access to the journal, the opportunity to belong to special interest groups, our community outreach, distance learning, the work of the foundations, the scholarships we give for this meeting? My God, all important, all reasons to belong, but that's not all, because belong is the key word, isn't it? Some of you probably remember the old Cheers theme about wanting a place to go, a place where everybody knows your name. Now, I hesitate to use that example, lest I seem to compare us with Dr. Fraser Crane. But you know the point. Through AGPA, we can connect with fellow professionals. We can learn from one another directly and through all the forms of communication and social media that we now participate with. We can make and receive referrals. In short, we can have a kind of home, a place where we're known as people and as professionals. If you've been at these annual meetings before, you probably know what I mean. And if this is your first, I'm sure you'll experience this for yourself. But the connections we form here and the bonds are something special. During our time here, we sometimes find ourselves exposed emotionally, and afterwards we're socializing with those same people. This makes for uniquely meaningful relationships. For myself, I've been going to dinner with 3 of my favorite groups of people for over 25 years. The stories we tell and the experiences are priceless. I'll never forget the one time I chose a restaurant in Chicago where it proved so expensive you had to leave your firstborn as payment. I now need approval from my Thursday group before any dinner reservations are made. Of course, when I need to make a referral out of state, the first place I look is the AGPA directory. Having a 20-person group practice allows me to make dozens of such referrals yearly, and I receive a fair number of referrals coming my way. I personally love being able to make referral to those I know are taking their practices seriously enough to be involved here, and it's a very real business benefit to receive those referrals, not to mention the difference one is able to make in someone's life to make a really good referral. And on a personal note, here's an example I hope you never have to experience. But I look around this room, I'm reminded of how many reached out to me during a difficult personal professional issue I recently had. These supporters included AGPA staff as well as professional friends. As I went through this, the calls, emails, and texts that encouraged and showed me the collective heart we all have. And we all go through challenging times. I think of the trials in life, including the passing of friends. I know how fortunate I've been to experience these with the support of AGPA and its members in my life. I hope you will find the same and that you'll take advantage of the opportunities to both give and receive support. Finally, I want to talk about the third reason I believe we should connect and support AGPA. That's because of the results that people get from our work. Life-changing results, sometimes life-surviving results. In short, we make a difference, don't we? And if it weren't for the ongoing training and access to other professionals with so much experience that adds to our own, we could not serve people the way we do. The fact is, each year when I return from this conference, I feel like an improved version of myself. 2 years ago, all the members in one of my groups commented I must have learned something new at the conference. They felt they could finally understand my comments about the group in a clearer and more meaningful way. It was just something that struck out to me about the impact of being surrounded by others and learning from those who are doing this work. Of course, just having them understand me isn't a key point, really. Having their lives improved is the key point. And I have felt for a long time that many of us do not fully acknowledge publicly how important and transformative our groups are in people's lives. What we do really works. A short example. About 3 or 4 years ago, my dear friend Elliot Zeisel, Elliot, where are you? Elliot. The person who was my dear friend, Elliot Zeisel, he referred a patient to me who had previously been in Elliot's group in New York. After Elliot's group, the patient moved to Toronto and joined a group led by Molin Lesh. I see Molin there. Okay, Molin. We're still friends. And this patient felt very positive about these group experiences. So when he moved to New Jersey, he wanted to join another group, and he came to mine. Unfortunately, when I initially saw him, he was extremely dysfunctional and very heavily self-medicating, which was a real challenge. But that's why we do this work, right? However, after 3 group sessions, he asked to say something at the end of the group, and he was always talking anyway. And he wanted the group to know that I was no Zeisel or Lesh. At that point, I wondered, how in the world am I going to help this guy? But over a 2.5-year period, his behavior in the group changed, and his outside life became much more functional and successful. I couldn't point out specifically how this change took place, but I feel sure that the 3 group experiences were cumulatively transformative. I may not be a Zeisel or Lesh, but the groups collectively did their work. Sometimes it takes a while. When he finally left the group, the other members commented how he was really a different person to relate to. Just one more story, an even happier one, before I finish up here, which will be the happiest. 15 years ago, a psychologist contacted me about joining our practice, as she was moving back to New Jersey from New York. She knew about our practice because when she was in high school, she babysat a child and brought him to his therapy session, and it turned out I was the therapist. She at that time was working at Cornell with Paulina Kernberg and had her group training with our own Howie Kybell. She suggested that our practice was really lacking. As a pediatric practice, we were really lacking a program, a social skills program, for children ages 3 to 12. And she also thought that our teen group program needed some beefing up as well. It was a sea change for me. These groups were structured, had a curriculum, take-home folders. What's more, seeing a waiting room full of parents, siblings, and children was cataclysmic for me. It looked more like a pediatrician's waiting room. In fact, a tough Wall Street type patient of mine said upon coming in one day, "You have so many kids out there, they're like locusts." But I quickly found out that the parents love these groups for their kids. The kids also seem to love coming, and today we often have a waiting list to get into more than 30-plus social skills groups for children. Most important, the improvement in their social skills and psychological functioning is impressive. We get calls from public schools, doctor's offices, and preschools, all telling us how much they like and support this program. I never could have started such a service myself. Yet the results are in, and we've seen children change, lives improved, and a clinical need that group therapy successfully filled. You could point out any one of these reasons as reasons enough to connect with AGPA, yet fortunately, we have all 3 reasons to connect. First, because it really does need to promote our work as an important key in transforming our national healthcare system. We can make this system work. We can pay for it, but only when we embrace a better approach. And that's what AGPA is calling for. Second, because we are supported and grow as individuals and professionals through our connections here at AGPA, through the educational opportunities, yes, but importantly through the relationships and bonds we form. And third, we connect with AGPA, and I'm personally grateful for it and so eager for its growth because I see a difference our work makes in people's lives. I see the transformations, as I know you do, and I'm sure we've heard many more stories that throughout this conference. Bottom line is that AGPA promotes our work, helps us to get better at it, all in the name of real results for people young and old, men and women, rich and poor, irrespective of sexual identity, cultural differences, as outlined in our Safe Environment Conduct Policy, our new policy. It's truly an honor to see this change, to be part of this change, and to be changed by it. And it's truly an honor to see you doing the same and to support you in this coming year by doing all I can to promote AGPA's mission. I thank you all for your work and for your friendship, and for the support I know I'll have from you in the years coming as well. And I hope you will get so much from your time here, not only from the talks and sessions, but from the friendships and conversations and the foundations you built here for your continued success in the years to come. But just remember one thing. As a number of presidents have said before me in their presidential address, first you got to put the chairs in a circle. Thank you very much.